sorry for this technical problem. So we continue to drill our area of the floor of the frontal sinus, okay, and to enlarge until the landmark. And I remind you that the landmark is the periosteum of the paracanthal area and paranasal area laterally, and the posterior limit is the posterior wall of the frontal sinus, and the anterior is the anterior wall of the frontal sinus. So don't hesitate to sculpt until this limit landmarks, and to open the both ethmoid to organize a very wide, not in fact wide, but very wide corridor, avoiding any stenosis as soon as possible. Yes, so it's possible also to remove the different sheet of mucocil with the dedicated process. So now the next patient is the installation of the next patient is down. So I'm going to speak about the medical history of the next patient. Okay, so I close this presentation and we change the. On change de. On regarde là-bas. Je te redonne ça. Ouais. So now. I'm going to do the presentation of the next patient. This is a 65 years old woman, and she suffered from this specific image with nasal obstruction and iterative suppuration. As you can see, this is a typical image of fungus ball. Typical because you have the hyperdensity, metal hyperdensity, and calcium hyperdensity in the opacity of the maxillary sinus. This fungus ball bulged the middle meatus and tried to exit from the middle meatus. And as you can see, due to the fact that she suffered from several periods of suppuration, you have hyperestosis of the wall of the sinus. You can compare with the other side. Look the thickness of this posterior wall of the sinus, okay, due to the fact that you have associate with the fungus ball chronic suppuration with acute crisis. So it's a polynuclear process. For the fungus ball, this is an eosinophilic process, and for suppuration, this is the polynuclear process which provoke this hyperestosis, osteogenesis. So the job is to completely remove all fragments of this pathology, if it's possible through middle antrostomy, and if it's insufficient through an inferior antrostomy. Okay, so I'm going to wash my hand and we are going to start in 2 minutes. start with this classical case of middle antrostomy. Okay, and as you can see, the access to the middle antrostomy is a little bit narrow. Okay, you have some few. I'm going to put in place some pledget cotton, please, with simetazoline. Okay, with straight forceps, please. Okay. I continue to try to retract the mucosa and to limit the bleeding in this very narrow space, of course, to do the surgery in good condition of visibility. Okay. And you can repeat, of course, this action on the other side. Of course, it's normal. Yes. It's normal. Okay. This woman is under anticoagulant medicine, which is stopped 3 days before the surgery. So now you can see here the middle turbinate here, the middle turbinate here, the middle meatus here, and the uncinate process here. So give me the Rouvier, the frozen blade, to start here the incision. Don't forget that on the CT scan, the uncinate process is bulged medially, so it's easier to do at the middle antrostomy. Look, beautiful. So straight scissors, please. Straight scissors, please. Okay. To cut along the back of the inferior turbinate. Okay. Now straight forceps. Like that. So now the maxillary sinus is open, like that. 45-degree forceps. Remove some granulation. Don't forget that even for a non-invasive fungus ball, you need to do histological samples to eliminate rare but possible invasive case. Okay, 45-degree forceps, please. Backbeating forceps. Like that. Okay. Okay. Of course, it seems that the bleeding is important, but it's a sign that you have a persistence of the mushroom, like that. Okay. Okay. So straight forceps, please. Tu peux appeler le suivant, s'il te plaît. like that. Okay. And with the vegan suction tube, you are able to tract and catch, because it's freeable, of course. Ok, non, pas encore. Yes, je passe derrière, and with like a hook, with my suction tube. I like that. Okay. So for the mycology and histologic sample. Okay. So another part. Okay. Okay. So now I'm going to wash, because I think it remains some piece of this specific disease. I'm going to wash with pressure. I don't hesitate to to do some pressure. It remains some pew. Okay. 45 long, 45-degree long process. Okay. And you can mobilize with your forceps the deepness, the contents of the deepness of the sinus. It's very useful sometimes to mobilize the remnant part of the. I think it's clear. Okay. So we continue to wash. Okay. Okay. Allez, donne-moi du lavage. Continue to wash, and I think that I'm going to perform an inferior antrostomy to control the inferior part of the maxillary sinus. So I put in place here on the middle meatus some pledget cotton, okay, with a straight forceps, okay, to limit the bleeding, because these old women had anticoagulant medicine. So I use all the time oxymetazoline, because I think it's a good drug. And we are going to put the patient in a proclive position. Tu peux rajouter du proclive to limit the bleeding. One time. Ouais, descends s'il te plaît. Merci. Qu'est-ce que tu racontes? Ouais, mais je vois. Parce que ça devrait plus saigner. Ça devrait plus saigner. Okay. So the anesthesiologist control also the pressure, the blood pressure. So now it's good. Yes. Okay. So I remove my budget cotton. Pass. Like that. Like that. Like that. Yeah. Okay. Way. Bravo. So, the maxillary sinus, it remains some few in the lateral part. Okay. And I'm going to elevate here the inferior turbinate, like that. Okay. Spatule, elevator. Là. Okay. Okay. Electrocautery device. And I'm going to cut here the mucosa. Okay. Feu. Toi. Stop. So now we are going to do a small hole in the bone here. Spatule. Okay. Like that. So, okay. So, straight forceps. Attends, aspire droite. Straight forceps and straight suction tube. Like that. Okay. So we have a lot of bleeding. But it's not. Okay. Back beating forceps, please. Well. Okay. Yeah. So straight forceps now. Right. Thank you. Okay. And now I'm going to penetrate in the maxillary sinus, but of course you have some granulation, and I'm going to wash through this small hole. Ouais. Bon, non, non, non. Non, vous ne respectez pas mon travail. Ok? Oui, bah, enfin, on est en direct. On est en direct. On a la planète en direct là. Donc, quand même. D'accord, vous êtes très important et pas moi. D'accord, ok. Donc, si vous voulez que je vous respecte, il faut me respecter. Mais il faut que ce soit réciproque. Sinon, c'est pas la peine. D'accord? Ok. Bah, s'il n'y a pas de problème, alors fais-le, s'il te plaît. Fais-le. Agis. D'accord? Parce que là, la tension n'est pas contrôlée. D'accord. Non, vous êtes en train de discuter de faire les courses. D'accord. Bah, tu as toujours raison et moi, j'ai toujours tort. Donc, c'est pas réciproque. Donc, tu te fous de ma gueule, en fait. Si. Bah, écoute, après l'intervention. So we continue to wash. Okay. So continue. Okay. Like that. Okay, I wash through the inferior and the middle antrostomy. And I keep, yes, of course, yes. So, look, this is the inferior part now. Okay, continue to wash, yeah, it's good. Okay, wet, vas-y, sors-le. Okay, it's fulfilled, yes. So, during this time, I take this. Okay. Okay. So you have some hematoma, of course, due to the bleeding. So we continue to wash. Control the deepness of this sinus. And hop, très bien. Ok, the middle antrostomy. On va remettre la digon. So we change the suction tube for the curved suction tube. Okay. So I put my endoscope in the inferior antrostomy. I'll try to do it. And on the middle, well, yes, I have my endoscope in the inferior antrostomy and my suction tube in the inferior antrostomy and my suction tube in the superior antrostomy, the middle one. So it's difficult to, yes, okay. So it doesn't remain some fungus bulb. Okay, so it's good. Sorry for the bleeding, but it's sometimes like that. Okay, so I remove the last granuloma, avoiding stenosis. Okay, like that. I think we are going to put some one mirror cell for a few hours. We will remove before she leaves the hospital. Okay, washing. Okay, good. It's good now. So the operation is finished. The inferior turbinate take placed normally in the nasal fossa. We have the inferior meatus here, the inferior antrostomy. Okay. And here, okay. So we put in place one mirror cell for a few hours. Okay, you have it?
Oui, je le coupe.
Ouais, recoupe-le comme une septo. Hein. Okay. So the bleeding is limited now, but I prefer to put this mirror cell, avoiding to put after the general anesthesia. So, yeah, good. So the operation is finished. And the next patient is a sphenocoanal polyp. So I take my phone if you want to ask some questions.